I'm sorry that I couldn't be there today, but my name's Ron Daniels. I'm an intensive care consultant in the West Midlands of England. I'm also the founder and chief executive of the UK-based charity, the UK Sepsis Trust, as well as one of the vice presidents of the Global Sepsis Alliance. And I'm here to talk about sepsis, severe infection, antimicrobial resistance, really what we've learned from the pandemic and what lessons we need to apply to our approach to infections management in the coming years and decades. I'm also going to touch on this because sepsis improvement programs, certainly in England, also in New York State, have been criticised from some quarters of health professionals for fueling antimicrobial resistance, for giving rise to an indiscriminate application of antimicrobials. And I hope I'm going to persuade you that pneumonia, sepsis, improvement programs in those time-sensitive infections are but the tip of the iceberg, that they're not the answer to slowing the growth of antimicrobial resistance. We need to look at a much broader problem. In terms of scale, and talking firstly across the United Kingdom, we estimate that we see around 48,000 deaths from sepsis every year, and no one is claiming that every one of those deaths is preventable. Of course, a significant proportion of those deaths are part of the natural dying process in people approaching the end of their natural lives. But for many of those 48,000 people, their deaths can be prevented through better communication, better systems design, better application of immediate therapies, and escalation where appropriate to intensive care services. To put this into context, and this is my local football club, Aston Villa, Villa Park holds around 43,000 people. Breast cancer around the UK, and these data are now a couple of years old because we don't have recent data for obvious reasons, but from Cancer Research UK, we see that breast cancer a couple of years ago claimed around 11,000 lives across the UK. Bowel cancer rather more, around 16,000 lives lost. And then just put that against the context of sepsis, the 48,000 lives lost each year. Now, of course, this gives the media the strapline that sepsis claims more lives than breast cancer and bowel cancer and prostate cancer combined, which is technically true. But as we've alluded to, many of these conditions will coexist. So is it appropriate that we double count? Are we being opportunist? Well, I would suggest not, because the goalposts for intensive care admission have changed over the 20 years since I've been a consultant. And now it's quite normal for us to be referred somebody perhaps who's being palliated with chemotherapy for breast cancer, who's developed neutropenic sepsis, and we will admit those patients. We might place some limitations, but we'll give them peripheral vasopressors. We might put them on CPAP because we just might get a chance of returning them home to their families for those precious few weeks or months. So I would suggest it is appropriate to double count because certainly the basics of sepsis intervention remain appropriate, all but in the final days of life. But I said I'd talk about the bigger problem, and the bigger problem is time-sensitive infection. We know from case series in the Western world, obviously in developing countries, the situation's slightly different with the prevalence of diarrheal disease and malaria. But in the Western world, 4 sources of infection give rise to around 95% of episodes of sepsis, being pneumonia, urinary tract, intra-abdominal, and then skin and soft tissue, bone and joint. So a couple of years ago now, just before the pandemic, we did a bespoke analysis, and this is for England only, of hospital episode statistics data. So we looked at the diagnostic codes pertaining to those 4 common sources of infection, and we did a head count. We did perform a little bit of a clinical construct, and we said, well, some of this will be jargon data, and the way we tried to exclude that in a very crude way was by excluding people who'd spent fewer than 72 hours in hospital. And during 1 year in England, there were 1.7 million admissions to hospitals in England that were either caused by one of those sources of infection or complicated by one of those infections. Clearly, this is a huge number. It's around a third of NHS workload in England, and it would be naive to think it wouldn't be a similar prevalence in the devolved countries and in other Western countries. The point I want to make here is that incentivizing better sepsis care does not mean that 250,000 people, the approximate number of people who develop sepsis each year in the UK, will get antibiotics at broad spectrum and fuel antimicrobial resistance. The reality is that with or without sepsis incentivization, pretty much every one of these 1.7 million people will receive at least one course of broad spectrum antimicrobials. Here's the problem when we're talking about hospitals, and obviously the problem is much bigger. We know that a much larger proportion of antimicrobials are administered in the community, and of course that 50% of antimicrobial load is in non-human consumption. But if we're focusing on hospitals, we need to focus here. We need to focus on the judicious use of antimicrobials in this population rather than trying to beat up incentivization programs for better sepsis care. The data I've shared with you, the 245,000 cases each year in the UK and 48,000 deaths, come from this study, which was released immediately before the pandemic hit our countries. The Institute for Health Metrics Evaluation is based in North America, and you may not have heard of them, but you will have heard of the Global Burden of Disease Report, and you will have heard of the WHO, of course. This is the organization that compiles the Global Burden of Disease Report for the WHO. So although these are estimates, they're estimates by the best estimators on the planet. And they estimated just before the pandemic that sepsis affects 49 million people worldwide, claiming 11 million lives, with a disproportionate affectation of children under 5 in resource-poor countries. Now, of course, again, we can put that into context, and the data for COVID here is slightly old, but the truth is every year sepsis around the world claims far more lives than COVID-19 did in its first year by a quantum of 2 or 3. Deaths from infection have been around for millennia, have been around for centuries, and in terms of their quantification, they are a much bigger burden to society at the moment than cancer, ischemic heart disease, and tobacco consumption. And governments really need to take this seriously. Lord O'Neill obviously produced his report some years ago now, in which one of the headline statements picked up by the press was that if we don't act now, then by 2050, we're going to see 10 million more lives lost as a consequence of AMR than we're seeing now. And I was as alarmed as you were at the recent report suggesting that, and it was shared by the WHO, suggesting that we saw 1.3 million lives lost as a consequence of AMR last year. So this is here now. I think some of the messaging around AMR can be improved because to public, it's not immediate and it's not personal. And we as clinicians know that it is immediate, it's here now, and it is personal, it is affecting families today. But I think Lord O'Neill was being optimistic because if we don't have effective antimicrobials, and 2050 is, well, it's nearly 30 years away, it's quite likely that antimicrobial resistance is going to become the norm for every patient we're treating between now and that point if we don't act now. I would argue that if we don't have effective antimicrobials by 2050, we won't be seeing an extra 10 million lives lost worldwide. We'll be seeing an extra 38 million because every one of those 49 million people developing sepsis will have an untreatable condition and will die as a consequence. Now, the point here is that this will tip the global human population balance from one of growth to one of decline. So when people talk about this as an existential crisis, and I know I'm preaching to the converted here, they're not exaggerating. I'm going to come on to talk around some of the improvement work we've done around the UK in sepsis. And I'm going to talk specifically about this bundle of care that me and my team developed back in 2006 that we call the Sepsis Six. Now, the Sepsis Six has iterated over time. It started by giving everybody high flow oxygen and giving everyone gallons of fluids and giving everyone broad spectrum antibiotics because the baseline then back in 2006 was very different. People with sepsis weren't being recognised. People with sepsis were presenting to acute sector healthcare very, very late indeed, often with septic shock and multi-organ failure. And of course, we've now come a long way. So it's iterated. And we now start with a senior clinician attending the patient. Critically important, of course, not only because some conditions mimic sepsis, and these people can seek an opportunity to de-escalate care or to move the patient onto another pathway, but also because these people can smooth the journey. Many patients with sepsis need interdisciplinary care. They might need input from radiography, input from surgery, and so forth, as well as considering intensive care referral. And senior decision makers can make those decisions much more quickly often. We now correct hypoxia rather than giving high flow oxygen to everybody. And we send a full set of bloods rather than just blood cultures, recognizing, and no one was diminishing the importance of the other bloods 15 years ago, but we of course recognize that it's important that we look for covert organ dysfunction as well as risk stratification, as well as pathogen identification. So we take U&Es looking for covert acute kidney injury, we'll measure lactate and other biomarkers, looking A, for risk stratification, but B, to try and differentiate between infective and non-infective causes of inflammation. And of course, we'll seek pathogen identification strategies. Step 4 hasn't really changed apart from we're bigging up the importance of source control, encouraging people to look for that source of infection and where it's amenable to source control, acting very rapidly. Step 5 is to give fluids far more judiciously than we used to. And step 6 is to monitor, including NEWS2, including serial lactates, and including urine output. One of the most important words on our tools that has been there since the very beginning on pretty much every version we've ever produced is down towards the bottom right here, variance. If somebody were to write in that box, I'm withholding antibiotics because the patient's presented with an acute abdomen and we know they've got gallstones, I think it might just be pancreatitis, so I'm waiting for an amylase, that's sensible medicine. That's exercising clinical judgment. That should be considered as fully compliant with the pathway. So this is not a thou shalt give antibiotics. This is a we empower you to if you feel they're needed. Now, if we could get this bit right every time, and of course, if every one of those senior clinicians was above average on that particular day, then we wouldn't need these empowering pathways. But the reality, and again, I apologize that this is English data, but the reality is very different. I see no reason this would be much different in the devolved countries. There's an NHS England clinical standard on this that all emergency admissions should be seen by a consultant within 14 hours. Now, these are self-reported data by hospitals to NHS England in response to this standard. So these are almost going to be biased towards over-claiming that we do this. In London, you've got about a 2 in 3 chance of being seen by a consultant within 14 hours. In the east of England, for example, it's about a 1 in 8 chance. So although we all have a desire to get competent decision makers to the patients rapidly, the reality is that we can't always deliver it. And therefore, we do need these empowering tools. In terms of the administration of antibiotics and considering source control, there have been some changes over recent months. And this is a screen grab from the October 2021 iteration of the International Surviving Sepsis Campaign guidelines. So they apply a grade methodology, it's multiple professional societies, it's very academically driven, and they appraise the often imperfect evidence and rate recommendations. And one of the most fundamental changes for October 2021 was in the timing of antibiotics. And they adopted a 2-tier approach to this. And the idea is that it will allow us to use antibiotics more intelligently, more judiciously in people who are slightly less sick. So the SSC say that if the patient has shock, and if you're pretty certain that the diagnosis of sepsis, then yes, absolutely, you get on and give the antibiotics within 1 hour. So either of those two conditions, shock or diagnostic certainty, get on and give antibiotics within 1 hour, as we've been doing for years. If the diagnosis is in doubt and the patient does not have shock, so that's a both rider, so there's no shock and the diagnosis is uncertain, then they're going to permit and recommend up to 3 hours for the administration of antimicrobials. Now, we welcome this, of course we do. It is sensible. We all know that the goalposts have moved since we started 15 years ago, and people are presenting earlier in their illness and getting better basic care than they used to. So it is almost certainly safe in this group of patients to wait a little bit longer before giving antimicrobials. But I'm not sure it's operationally relevant within certainly the NHS where I work and possibly the NHS in other parts of the country. Because I'm pretty sure I don't have any more information at 3 hours than I did at 1 hour. I'm certain I'm not going to have any rapid pathogen identification strategies back yet. That can happen in some hospitals, particularly in London, certainly doesn't happen in mine. I'm unlikely to even have my basic blood test back within 3 hours. So whilst we welcome this, we need to ensure that it can be delivered safely. The other issue that I have with this is that we know what happens to patients. They flow through the hospital. They come in at the entry point, they get a touch point with a clinician, and that's where the diagnostics or the presumptive diagnostics and the immediate interventions are delivered. If they're not triggering at that point, If you say 3 hours, it becomes the next person's job. They're likely to be sent to the ward, and then unless they deteriorate and trigger on news overnight, it might not be until the post-take ward round before someone thinks to act on the antibiotics. So we welcome this, but I think we really need to consider whether A, it's going to make a significant impact on prescribing practice, and B, whether we can do it safely without any significant delays. Now, many of you will be aware that there was a commissioning incentive across English hospitals for sepsis from 2016 to 2019. I think it's difficult to cast any doubt on the fact that process improvements were huge. We went from antibiotics within the first hour rising from 32% to 80% in just 3 years. But those were self-reported data, and there were some accusations of the possibility of gaming within these data. And I think we have some fairly soft evidence that that might indeed have been the case, because other organizations have been reporting in a less financially incentivized way during the same time. And this was the most recent output from the National Emergency Laparotomy Audit. And they've always looked at sepsis, and they find that actually the processes are not quite as reliable as the NHS England data would say. A third of patients don't get their source control within the recommended timeframe, and only just over 1/5 of patients, 1 in 5, get their antibiotics within the first hour. So these are people who are being dealt with by senior clinicians. We've got more than 80% now attendance by consultant anaesthetist and consultant surgeon, but they're still not getting the antibiotics in time, and they're still not getting into the operating theatre on time. I think another issue we have is antimicrobial de-escalation. It's great in theory, and few can argue against the theory with any vigor, but it's not practiced. And why is it not practiced? It's because there's some hesitancy around it. This was a publication quite recently. It was only a couple of years ago now, and it was in the intensive care literature, and it was expressing this hesitancy around antimicrobial resistance, suggesting that antimicrobial resistance might result in more prolonged, that de-escalation of antimicrobials might result in more prolonged administration of narrower spectrum antimicrobials, might result in multiple courses, and it might itself propagate, if it's practiced reliably, this desire to give everybody a carbapenem at the front door, and that we shouldn't allow that to happen. So clinicians are not fully invested in antimicrobial de-escalation at the moment. And again, another study that the therapeutic effects of de-escalation in sepsis remain unclear. Do we do it? Well, we sort of do, but certainly on my intensive care ward rounds with my infection specialist, I quite frequently am having a conversation where we've grown a bug. It might have some sensitivity to a narrow spectrum, but because they've been on PIP-TAZ for a couple of days, we say, well, let's just give that for up to 5 days because they're getting better and the diagnostics might be wrong. And this study was quite interesting. It showed that positive results and sensitivities yielded by blood cultures don't seem to have much impact on the reliability of de-escalation. And you'll see there that the proportion de-escalated in their antimicrobials by 96 hours between positive and negative cultures was almost the same. So we need to understand how we can better integrate diagnostics, how we can use them to impact on prescribing behavior, how we can use them to impact on culture, rather than just looking at the technology and the science in isolation. Because the reality is different to the perception. Often when we're speaking to companies, they have exercised significant effort in engaging laboratory clinicians and laboratory scientists, but there's a lack of understanding sometimes, all too often, in fact, of what's actually happening in terms of the gap between the technology and the information reaching the front line. So people with COVID-19, obviously that was an X-ray of someone with COVID-19, and thankfully at the moment in my hospitals, we don't have many patients with it, and let's hope it stays that way. But nice, of course, and there were some fantastic learnings with COVID-19. We accelerated guidelines like this, we accelerated research, we worked together fantastically, we broke down interprofessional barriers. There was a lot of positivity around the NHS's response to COVID-19. The NICE guideline recommended, or rather stated, that actually co-infection with bacterial pathogens is pretty rare, that it occurs in fewer than 8% of people with COVID-19, and maybe, and I'm not sure I believe this, as low as 0.1%. So 1 in 1,000 people hospitalized with COVID have bacterial superinfection. Now, whether we believe those absolute figures or not, this clearly suggests that actually bacterial co-infection is far less common than we might have originally thought. NICE went on to make recommendations around how we should look for bacterial co-infection, how we should seek to exclude it rather than include it primarily by using a combination of biomarkers, bronchoalveolar lavage, and clinical assessment. And they recommended against the use of procalcitonin, but procalcitonin was rarely used in my intensive care units before the pandemic. It's now in routine use as part of the armamentarium. We shouldn't be doing studies saying, is procalcitonin in isolation of utility? We should be looking at studies saying, does procalcitonin assist with clinical decision-making? Let's use it for the purpose it was intended. Does it help to support my decision to withhold or stop antimicrobials in my patients? Absolutely, it does. NICE recommended that we started empiric antibiotics if there was clinical suspicion of a secondary bacterial pneumonia. Is that what happened? Absolutely not. Everybody got antibiotics, near enough. So this was an interesting study. Again, it was around the intensive care population, and it found that half of studies included in this meta-analysis showed, systematic review, showed 100% of patients receiving antibiotics, whereas in 90% of the studies, near enough, more than half of patients received antibiotics. So we were giving antibiotics out willy-nilly in people with COVID-19. Why? Well, we know that there are rapid biomarker tests available. We know that there's rapid diagnostic tests available, but we don't get them. We don't access them. One example, procalcitonin. My hospital batches PCT to be done on a Tuesday and a Friday. And so if I send a PCT, it might be 48 or 72 hours before I get the result back. What's happening in that time? My patient's receiving, hopefully, coamoxicillin, coamoxiclav, clarithromycin or equivalent, but all too often piperacillin tazobactam or meropenem because someone has thought, well, they're ill enough to be in intensive care. So we're using antibiotics pending the availability, and similarly with antifungals, pending the availability of useful tests, because we don't have these tests accessible at the point of care in a timely fashion. We all know that these tests take half an hour or so to yield a result. So why can't we better integrate them into our healthcare system? Another example, patients with normal community-acquired pneumonia that we suspect to be bacterial rather than viral in origin. And again, there's nice recommendations on this, that we use combination therapy. Largely, we're applying the macrolide type antibiotics just in case there's a coexistent or just in case the pathogen is an atypical pathogen. Do we see these often? Well, no, we don't. Of course we don't. So prior to the pandemic, and these are English data again with apologies, we saw just under 500 cases of Legionella among around 1 million cases of people hospitalized with pneumonia every year. During the pandemic, that dropped to fewer than 300 cases. So what are we doing? Well, we're giving all of these 1 million people these combination therapies just in case there's a coexistent atypical pathogen, because we can't access the diagnostic test rapidly. Again, these tests are batched. If I send a Legionella antigen from urine, it will be 3 days all too often before I receive it back. These tests are not slow tests. They're not tests that require exhaustive validation. They're available, and we need to integrate them better and get the information more rapidly to the point of care clinicians. And while we're on the point of care clinicians, we need to get them into the labs. We need to make them understand that all of these myths they hold around blood cultures, and these, by the way, are mostly the reasons why our junior doctors don't take blood cultures very well, don't take them very seriously, because they've never been inside a lab. They don't understand that the processes have moved on since the pictures they saw in their textbooks as medical students. They think it's obsolete. They think it's century-old technology. They think everybody's just sitting in a lab with agar plates in a darkened room with a Bunsen burner in the background. They don't understand that actually, if they do these properly and make sure they get to the lab in a timely fashion, they could get results that can impact on their prescribing within a few hours in some cases, rather than the often purported 72 hours it takes as a routine. Let's engage with our junior health professionals. Let's get the culture around cultures better. Let's improve the systems and the processes to transport them to the labs and get them into the incubator. And then we can start really making a difference. I think, we can't have a talk like this without talking about molecular diagnostics. And I'm in no way an expert on this. But again, this is about integration. This is not about taking, for me, molecular diagnostics into a laboratory and exhaustively comparing them against the gold standards. This is understanding how algorithmically we might safely be able to integrate them into a near patient setting. how we might be able to, not by putting them on a benchtop in an intensive care unit, because some of them require much more technical skill than an intensive care nurse or doctor would have, but by improving the speed with which we conduct tests, by bringing the information closer to the patients, and by accepting imperfection. Can we use algorithms to help us to safely prescribe based upon these results, interpreted in the context of clinical data, and accepting that we might get more accurate data coming through in the course of time? But there's simpler stuff that we can do right now. There's simple devices that we can use to discard the first 1.5 mils of blood from every blood culture. They're relatively inexpensive, and they've been trialed in hospitals like Guy's and Tommy's to show that they reduce the incidence of false positive by as much as 66%. So in itself, that is sparing the needless use of antimicrobials. But it's also improving the culture around cultures. It's improving the faith of our junior health professionals in blood cultures and really engaging them in the process. Let's stop giving them mandatory training. Let's start telling them why. Let's start showing them why, and then they will become engaged. And just imagine if we got this right, if we had an integrated system of devices, near patient tests, integrated in the healthcare system in a safe manner, with people empowered to use them and willing to communicate and ask for help. And that's what, and this is just to finish, this white paper talks about. It's called the Infection Management Coalition. The website title is on the top left. This was a paper that we've created alongside industry, alongside regulatory bodies of industry, and alongside professional societies and advocacy organisations. So this is underwritten by the British In Vitro Diagnostics Association, the ABPI, the ABHI, and others. It's supported by the UK Sepsis Trust. We held secretariat to it. It's supported by the British Society for Antimicrobial Chemotherapy and other major players. And one of the key messages, and there are 29 recommendations, and it does talk about this better integration of point of care diagnostics, is a policy level statement, encouraging governments to stop producing AMR strategy papers and sepsis action plans with a different group of people, but to consider infections management holistically. There are 4 pillars: antimicrobial resistance and stewardship, rapid treatment of time-sensitive infection, particularly sepsis, infection prevention strategies across the board, and outbreak surveillance and pandemic preparedness. And if we address these 4 pillars with equal vigor in an holistic picture of infections management, we will probably achieve a lot more and actually deliver a suitable legacy to those who've succumbed to COVID-19. So I'm not going to go through to all 29 recommendations, but just highlighting a couple of what to me are the critical ones. This is around rapid appraisals by NICE of new infectives. We also talk within this about better funding mechanisms for anti-infectives and a value-based funding system. We talk about, as I've said, the greater integration of point-of-care diagnostics, commissioning criteria for optimal infections management. We shouldn't be talking with a few metrics that can be subject to gaming around sepsis improvement, but we should be commissioning for an holistically better infections management strategy from our providers. And I think a critical point is public awareness of these issues. There are vulnerable members of our society, people with risk factors for both sepsis and the presence of antimicrobial resistant organisms. We need to really get into those people, deliver storytelling messages, engage them in this, improve their behaviour, and get them to present to healthcare quickly. Now, finally, to finish, we're in the business of raising public awareness. Some of you listening will have access to community groups, to schools, you might run businesses. We've got a free set of resources called Sepsis Savvy. It's available on our website, and it's a short online video together with a little electronic game that can be delivered as a package to people within 10 minutes. It's intended for non-health professionals, for lay people, to equip them with life-saving information to help to safeguard their family and friends. It's absolutely free. Please do have a look for it. So that's all I wanted to say. It was an overarching view through sepsis in the context of severe infection and AMR in the post-COVID landscape. Thank you for listening.